Even with all the leaps we have made in endodontics, a massive segment of our profession is still actively choosing to stop right in the middle of a perfectly good root canal. Picture this scenario. You're sitting chairside, the patient's anesthetized, and you have just finished shaping the MB2 canal and the maxillary first molar. Isolation is great, your canals are clean, you dry the canals, but instead of reaching for the sealer, you stop. You pump in some calcium hydroxide, pack some temporary material on top, and you tell the patient that you will see them in 2 weeks. Why do so many skilled clinicians still do this? Because a professor 20 years ago told you that necrotic teeth with periapical radiolucencies need time to heal before you can safely obturate them. They warn you that closing a hot tooth in one visit guarantees a massive weekend flare-up. Today on The Research Says, we're putting this exact clinical dogma under the microscope. We are going to look at the highest levels of endodontic literature to see if you are actually improving clinical outcomes or simply just destroying your practice efficiency based on fear. Let us look purely at the underlying science. Apical periodontitis obviously is a bacterial infection. It's driven by biofilms and bacteria inside the root canal system. The entire objective of endodontic therapy is to reduce that bacterial load below that critical threshold where the patient's immune system can facilitate periapical healing. Historically, the belief was that our hand files and our passive chemical irrigants were just not adequate to eradicate those biofilms in a single sitting. The two-visit approach relied almost entirely on the antimicrobial properties of calcium hydroxide. The theory was that leaving this highly alkaline paste inside the canal space for 2 weeks would allow hydroxyl ions to slowly diffuse through the dental tubules, killing off residual bacteria. That theory sounds good until you realize how drastically our mechanical technology and our fluid dynamics have evolved. We are no longer relying on stiff hand files and passive irrigation. We use highly flexible nickel titanium rotary systems that shape the canal efficiently, and they create an ideal reservoir for more irrigants. And more importantly, we now utilize active irrigation. Ultrasonic and sonic devices, they can create like an intense acoustic streaming and cavitation, driving the chemical agents deep into the microscopic anatomy. The objective has not changed, but our mechanical ability to achieve it in a single appointment has completely transformed. So what does the evidence actually tell us? We are looking at the absolute apex of the evidence pyramid. So an updated Cochrane systematic review published in 2019 looks specifically at single visit versus multiple visit endodontic treatment. This is a massive aggregation of over 30 randomized control trials following patients for over 5 years. The findings were very clear. There was no statistical difference at all in long-term healing between single visit and multi-visit groups. They found no significant difference in radiographic success. The highest level of evidence dictates that routinely placing calcium hydroxide and waiting weeks does not yield a higher clinical success at all. The Cochrane review did observe a slight increase in short-term post-op pain in that 24 to 48-hour window for some single-visit cases, but the true flare-up rates were entirely similar between both groups. Real emergencies happen at the exact same rate whether you finish the tooth in one visit or two. Knowing there might be a slight bump and mild discomfort just means that you might adjust your pharmacological management. Give the patient a long-acting local anesthetic like bupivacaine before dismissal, and then put them on some scheduled regimen of ibuprofen and acetaminophen. You don't abandon an efficient clinical protocol just because a patient might need over-the-counter pain management the next day. We see this exact conclusion corroborated across major endodontic journals. There was another landmark systematic review by NG and colleagues in the Journal of Endodontics, and it analyzed thousands of teeth to find what predicts long-term success. Success rates are heavily driven by the preoperative periapical status, the quality of the obturation, and crucially, the quality of the coronal seal. The number of visits was not a factor. A separate meta-analysis in the International Endodontic Journal found that using calcium hydroxide as an inter-appointment medication did not significantly improve healing outcomes. There's another randomized control trial specifically on necrotic teeth, and it found no difference in one-year healing and no difference in flare-ups compared to a well-executed single visit. So the verdict is actually much clearer than most things that we look at here. Single-visit endodontics is exactly as effective as multi-visit treatment. Accepting this research as fact will fundamentally change how you view your practice overhead and your profitability. Bringing a patient back introduces massive operational efficiencies, and between appointments, that temporary filling is a major clinical liability. Temporary materials break down, wash out, and leak under occlusal forces. And once compromised, saliva and toxins travel straight down the canal system that you just spent an hour disinfecting. By leaving a temporary in place, you actively introduce new bacteria. That NG study proved that the coronal seal is the primary driver of long-term success. A single visit approach bypasses the leakage risk entirely. You finish your obturation, clean the chamber, and place a bonded composite core immediately while the rubber dam is still isolating that field. So transitioning to a single visit workflow eliminates the no-show risk entirely and massively improves the patient experience. Nobody wants a mandibular block twice for the exact same tooth. Let us look at the simple math. Every time your patient sits in your chair, you incur tons of fixed costs and overhead. You pay your assistants to break down the room and you set up a new tray. You consume disposable barriers and your own highly valuable clinical time. If your fee for a molar root canal is $1,200, doing it in one 75-minute appointment makes it pretty profitable. If you split that across a 60-minute access appointment and a 45-minute obturation appointment, you decimate your opportunity to make any money. That second visit is time that you are not diagnosing new treatment or prepping a crown. By finishing in one sitting, you reclaim lost time and you open up space for a same-day crown workflow. How do you apply this evidence tomorrow morning? Well, pretty easy. Just build a clinical protocol that maximizes disinfection in a single sitting. Start with great anesthesia and a rubber dam, achieve straight line access, and use your rotary system to open the apex and allow enough irrigation to get within 2 millimeters of your working length. You need a lot of full-strength sodium hypochlorite replenished constantly. You must incorporate active energy-driven irrigation. Use an ultrasonic tip to agitate the bleach, break surface tension, and mechanically disrupt the biofilm, and then flush out all the hidden isthmuses. This aggressive step is what replaces 2 weeks of calcium hydroxide. Once your canals are actively disinfected, use a final rinse of EDTA to remove the smear layer, followed by a final flush of sodium hypochlorite. Dry the canals all the way with paper cones, and then if those cones come out dry with no persistent exudation or active pus, you are clear to obturate. Achieve a great dense fill using a warm vertical condensation method or a bioceramic sealer. Then immediately place your core buildup to permanently seal the orifice. You can then prep the tooth, take your digital scan, and place the final. There will always be rare clinical exceptions. If you encounter an acute apical abscess with active, unstoppable pus draining through the canal, you probably can't really obturate. Complex retreatment cases might also require a second visit, but for the vast majority of routine cases, the single visit approach is far superior. You have permission from the highest levels of endodontic literature to stop doing 2-visit root canals out of sheer habit. You can confidently provide single visit care while running a much more efficient and highly profitable practice. Let's keep working together to make dentistry fun, fulfilling, and rewarding. Subscribe so you don't miss the next strategy, and I'll see you soon.